As the neocortex loses its cholinergic pathways, the resulting deficit translates into a progressive loss of memory and behavior. This decline is often most evident in the frail geriatric patient, such as a 78-year-old male presenting with mild to moderate Parkinson's disease dementia. In this case, the cognitive baseline is further complicated by profound apathy and emerging delusions, symptoms that define the behavioral and psychological burden of the disease. His clinical chart reveals a dense polypharmacy burden. To manage existing comorbidities, his daily regimen already includes levodopa for Parkinson's motor symptoms and beta blockers for hypertension. To address the cognitive and behavioral decline, the clinical team initiates treatment with rivastigmine. Managing this vulnerable patient requires a total deconstruction of the drug's dual enzyme inhibition, its unique non-hepatic clearance, and the strict titration rules that govern its use. The underlying deficit in dementia involves the progressive degeneration of cholinergic neurons in the neocortex, which are the primary regulators of memory. Rivastigmine's primary mechanism pseudo-irreversibly inhibits central acetylcholinesterase, specifically the G1 form concentrated in Alzheimer's brains. This increases acetylcholine within the synapse. In later stages, it also disables butyrylcholinesterase, a byproduct of gliosis, targeting dual enzymatic pathways to maximize cholinergic availability. This secondary action carries a theoretical neuroprotective bonus, as inhibiting butyrylcholinesterase may interfere with ongoing amyloid plaque deposition. Ultimately, this dual inhibition strategy attempts to squeeze every possible fraction of acetylcholine out of a dying neural network. Returning to the patient's medication list, the clinician must find a way to introduce a neuroactive agent without triggering a cascade of metabolic drug interactions. This flowchart highlights rivastigmine's defining pharmacokinetic trait. It bypasses the liver's CYP450 system entirely. The drug relies on hydrolysis directly at the site of action, making metabolic drug interactions virtually impossible for elderly patients on complex regimens. Despite its sustained clinical impact, the drug has a paradoxically short elimination half-life of just 1 to 2 hours. Non-metabolic risks remain. When combined with the patient's existing beta blockers, the drug's cholinergic activity can cause severe bradycardia or syncope. There is also a theoretical risk of antagonizing the patient's levodopa therapy, which could potentially worsen motor symptoms. Rivastigmine's non-hepatic clearance removes the risk of metabolic interactions in geriatric polypharmacy, but it necessitates continuous monitoring of cardiac and motor function. During the initial oral titration phase, the patient experiences severe nausea and anorexia, leading to a dangerous drop in body weight. This peripheral inhibition of both acetylcholinesterase and butyrylcholinesterase disrupts the gastrointestinal tract, a severe complication that is further exacerbated by the drug's central enzymatic blockade. Rapid weight loss and muscle wasting pose a severe threat to low BMI geriatric patients. Mechanical absorption through dermal layers allows the drug to enter the bloodstream directly, bypassing the gastrointestinal tract and reducing severe side effects. The clinical team pivots to the transdermal patch, maintaining therapeutic levels while mitigating GI toxicity. The conversion protocol is strict. Since the patient was receiving less than 6 milligrams orally, they switched to the 4.6 milligram 24-hour patch. Transdermal delivery provides the systemic exposure necessary for efficacy, while shielding the vulnerable gastrointestinal tract from direct cholinergic stimulation. Patch application requires precision. It must be applied only to dry, intact skin on the upper torso or outer arm to ensure proper absorption. To prevent dermal necrosis, the application site must be rotated daily, and the same spot cannot be reused for 14 days. Crucially, only one patch may be worn at any time. If a caregiver misses the application for 3 consecutive days, the lapse triggers a critical safety protocol. This timeline illustrates a critical safety protocol. If 3 days are missed, treatment must restart from baseline. Resuming at the maintenance dose causes a massive peripheral cholinergic spike, resulting in violent emesis that can lead to a fatal esophageal rupture. A single lapse in administration transforms an effective cognitive enhancer into a significant physiological hazard. By week 6 of transdermal maintenance, the patient's cognitive decline stabilizes and the initial gastrointestinal distress resolves. Measurable behavioral improvement can take up to 6 weeks to manifest, while confirming disease stabilization often requires several months. The drug addresses the behavioral and psychological symptoms of dementia directly, reducing the apathy and delusions observed in the patient. Beyond memory loss, the drug is recommended for hallucinations in dementia of Lewy bodies and for managing hypersexuality, a symptom that donepezil has been reported to exacerbate. Effective rivastigmine management relies on this clinical triad: understanding its dual enzyme mechanism, navigating its zero-CYP pharmacokinetics, and utilizing transdermal delivery to manage GI toxicity. While we cannot reverse the underlying neurodegeneration, precise pharmacological management can alter the trajectory of behavioral decline and preserve functional independence.